The following podcast is part of a certified educational activity titled Moving Forward in BALL. Insights on modern and emerging standards with off-the-shelf bispecific antibodies. Access the entire activity and complete the post-test at peerview.com/AEN860. Downloadable slides and practice aids are also available.
Good morning, everybody. My name is Nicola Göckboget. I'm from Frankfurt, Germany, and I chair the German ALL study group for adults. I welcome you. I am happy that some of you found the way here in this huge Congress Center and at this early time in the morning. So thank you for coming, and also welcome to the online audience. So today our topic is moving forward in BALL. Also another very interesting approach, which I want to specifically mention, is the HealthTree Cure Hub. It's a very prestigious approach to involve patients with different offers for education, for example, conferences, guiding patients through their treatment. And I just spoke to the colleague representing this company. It's really interesting and encourage you to learn more about it. Now, we had a dramatic, revolutionary development in the management of ALL in the past decade, starting with the approval of blinatumomab in relapsed refractory ALL, also inotuzumab, and the two different compounds for CAR T-cell treatment, all in the later stage of disease. But the biggest step forward was certainly the approval of blinatumomab in the MRD setting, the first compound which was approved in this setting. And afterwards, the approval was expanded also to use in MRD negative patients as the most recent FDA approval. And a third compound, obe-cel, was approved for relapsed refractory ALL. This is all FDA, and I am well aware that in many countries in the world, these compounds are probably not readily available, but hopefully will be in the next future. Now, not surprisingly, immunotherapy is a very attractive approach in ALL because targetable molecular aberrations are rather rare. So therefore, the surface antigens are an excellent target. And these are CD20, which was the first approached surface antigen, which is available in about 40 to 50% of the patients. And most recently then CD22 and CD19, which is present in most of B-precursor ALL cases. With standard chemotherapy, pediatric-based regimens, but also the integration of newer antibodies into intensive chemotherapy approaches like hyper-CVET, we have achieved a lot in our patients in the past decade. You can see here on the left side the MD Anderson results in adolescent and young adult patients. On the right side, the recent Italian study, which was a pediatric-based approach using blinatumomab 2 cycles in first line. So we have achieved a lot, but there are still room for improvement. Particularly, we didn't reach the same cure rates in adult patients than in pediatric patients. And you can see here on the right side a broad range of 40 to 70% of the patients surviving in the adult setting. And this mainly depends on age. So within the adult setting, age is one of the most important prognostic factors. And it's quite shocking to see these data here. It's from 2019, Medicare data in older ALL patients treated between 2007 and 2015, that a large number of patients were not even treated in the older age. It's hard to believe because more than half of these patients are probably Ph positive and could at least be treated with a TKI. And also the number of patients receiving chemotherapy or combination with TKI or chemotherapy only is rather low. Maybe this is historic data, maybe this is the real world, or maybe our US colleagues can comment on that later in the discussion. But I think there is really room for improvement because we can do a lot also for these older patients. Another complicated issue is the MRD testing. The MRD testing has several prerequisites. You need the option to get payment for the MRD payment in your healthcare system. You need to have a protocol and know when to do the MRD testing and which treatment conclusions to draw from these MRD testing results. And in a rare disease like ALL, it's rather complex to bring this information also to smaller sites, which really see very few patients per year. I can also say this for the German setting, where in our setting, 150 hospitals in Germany treat ALL patients, and more than half of them have one patient per year. And it's also evident here from the survey showing that MRD testing is well known, but there are insecurities about when to test it, which test to use, a commercial or in-house. I would not recommend in-house because you need standardized settings. The interpretation is very important and to draw conclusions from that. And on the bottom line, you can also see the insurance coverage is an issue. And I hope that when we have more data on the use of new compounds in MRD setting and react on MRD, that more authority in healthcare systems will accept and fund also this type of evaluation. Now today we have the goal, through the presentations of my colleagues, to learn more about the scientific rationale to use blinatumomab in Ph-negative and Ph-positive ALL first line. Always better to use effective drugs in ALL in first line, not in later lines. New evidence that newer CD19 bispecifics are also highly effective in relapsed refractory ALL, and even work in patients who had prior CD19 therapies. This is important because still we will observe relapses in these patients. And then the setting of the use of bispecifics in ALL gets more and more complex. It will be more personalized. We need to decide in which patient to use it, in which backbone therapy, depending on MRD or not, and which are the important disease-related factors to decide on the use of blinatumomab. And also on subsequent therapies, for example, stem cell transplantation. So maybe our whole setting of risk-adapted therapy will change in the next future. And finally, it is very important also to handle these compounds well, particularly in hospitals, again, who have not a lot of experience. These are specific toxicities. They can be handled, but you need some experience, and safety considerations are very important for optimal use. So this is my introduction, and I would like to introduce now Nicholas Short from MD Anderson to give us a talk on opening the door, setting the standard with bispecific antibodies in ALL. Thank you.
So yes, thank you very much for the introduction and to PeerView to the invitation to speak. So I'll be talking about bispecifics in ALL, kind of where they stand in terms of current standard therapy. So here is just a kind of a schema of how we currently treat patients with ALL, newly diagnosed ALL in the modern era. So we can think of, Burkitt leukemia, sort of a very separate condition. This is where we integrate, of course, very intensive chemotherapy and rituximab. Philadelphia chromosome positive ALL, where we use, of course, a TKI, but now with a chemotherapy backbone, and more recently with blinatumomab as a chemotherapy-free regimen. In Philadelphia chromosome negative B-cell ALL, we're integrating blinatumomab as standard of care in the frontline setting, as we'll discuss, sometimes with inotuzumab, either with a hyper-CVAD, for example, adult backbone or pediatric backbone. T-cell ALL, which we won't really talk about much in this talk today, but this is where we really lag behind because we don't have these very potent immune therapies like we do in B-cell ALL. And then ultimately, for these diseases, we're getting much better outcomes. We need to integrate the underlying biology, MRD status, to make decisions about, for example, stem cell transplant or CAR T-cell therapy, et cetera. So how do we use bispecifics currently in ALL? And really we're using, and really right now when we're talking about bispecifics in this context, we're talking about blinatumomab. We use it across the disease landscape. So we use it as consolidation, as we'll discuss, in patients with newly diagnosed disease, really as if they're MRD positive, that's been standard for a long time, or if they're MRD negative, we use it as consolidation. We use it, as I mentioned, with the chemotherapy-free regimen for patients with Philadelphia chromosome-positive ALL. We use it as part of maintenance therapy for some regimens. For example, with the hyper-CVAD blinatumomab regimen, the blinatumomab is also integrated into the maintenance. And of course, really where we started with this was for relapsed refractory disease, although I think there's less use of it in relapsed refractory disease because we're using it in the frontline setting, and also fortunately we're getting much better outcomes in the frontline setting, and I would argue that we're seeing fewer patients relapse in the current era. So this is just the data that led to blinatumomab approval in relapsed refractory ALL. We won't spend a lot of time on this, but you can see that blinatumomab, compared to conventional chemotherapy for patients with relapsed refractory B-cell ALL, improved the survival, specifically the median survival. So you can see an improvement in the median survival from 4 to 7.7 months. But unfortunately, you can see that tail of the curve really was not altered by the use of blinatumomab. And really the long-term survival for these patients with relapsed refractory disease, certainly when you use these agents, blinatumomab or inotuzumab, et cetera, when you use them as single agents is really limited, and I think there's a role for kind of more combination, more aggressive approaches for patients with relapsed refractory disease, but with blinatumomab being an important component of that. We're going to talk a lot about blinatumomab in different treatment contexts, and so I think it's just important to talk about the toxicities that we see with blinatumomab. I think these are really quite manageable, so particularly it's cytokine release syndrome and neurotoxicity. Importantly, with cytokine release syndrome, we do see an association with the disease burden. So you can see, for example, in the relapsed refractory study, CRS rates were higher than they were in studies for MRD positive disease or as consolidation. Neurotoxicity, there's not as really a clear association with disease burden. But as I said, I think these toxicities are certainly ones that clinicians need to be aware of, but really early recognition of these, stopping the drug, giving steroids, resuming at a lower dose, escalation, all of those, I think we can relatively easily mitigate these in our patients. And so, as I mentioned, blinatumomab now is approved for, consolidation regardless of the MRD, but I think we will be talking a little bit of MRD, so I think it's important to kind of conceptualize what this means and how we should be interpreting this. So, MRD is really just a measure of the disease burden, right? So we confuse patients sometimes and we say, well, you're in complete remission, but we still see residual disease, which is a little confusing because you can be CR but MRD positive. And of course, there's different trajectories that the patients can have. There can be patients that, are MRD, never achieve MRD negativity, and we know unless, we can consolidate them and get them into a deeper remission, they will eventually relapse. But unfortunately, we can also have patients who can achieve MRD negativity and eventually relapse. And I think that as we have more sensitive assays like these next generation sequencing assays, I think we're better able to risk stratify these patients. So I just wanted to spend a little bit of time on sort of how we use MRD in clinical practice. So certainly, at least in the US, we prefer to use these next generation sequencing MRD assays. Specifically, we have the clonoSEQ assay, which is sensitive down to 10 to the minus 6th. There are alternatives, flow cytometry, PCR for BCR-ABL, but this is really going to give the best discrimination for relapse risk. When do we do the testing? So in a newly diagnosed patient, certainly I would always do it after induction. And then really I do it personally every cycle until that patient achieves MRD negativity with this deeply sensitive assay. And then after that, every, about 3 months. And then it's kind of questionable how long to continue that for, usually for 2 to 3 years. So what do we do based on the MRD status? Well, okay, so first of all, as I mentioned, if you're MRD positive after initial therapy, the standard for several years has been to initiate blinatumomab. Of course, as we mentioned now, even if patients are MRD negative, based on the E1910 data, which we'll discuss in a bit, blinatumomab is still the preferred agent. That being said, there are other agents that are also active for MRD positive disease and have a role particularly for patients who've had prior blinatumomab, such as inotuzumab or even CD19 CAR T-cell therapy. So how do we use this for transplant decisions? I mean, I think there's a lot of data that patients who achieve a deep MRD negativity may not benefit from transplant. This is particularly the case for patients who otherwise have standard risk, cytomolecular disease. If they achieve rapid MRD negativity, those patients we generally do not refer to transplant. I think for patients with high risk cytomolecular features, even if they achieve MRD negativity, it's always an individualized decision. And then if we know that MRD is very important after CAR T-cell therapy or after transplant, we should be monitoring these patients. And those patients, for example, who undergo CAR T-cell therapy, if they're still MRD positive, particularly after 3 months, those patients have a very high risk of relapse. And usually we would either give them alternative therapies, including stem cell transplant. And then lastly, I think there are some, this is kind of going to be outside of the scope of discussion, although happy to discuss it maybe in the Q&A section, but I think there's a lot of challenges to interpreting these NGS MRD assays, and there is an art to it, and a science, of course, but it can be challenging. Okay, so now moving on, since we got a little background on MRD, so again, blinatumomab was also approved for MRD positive disease based on Dr. Gökbuget's data from the BLAST study. So you can see in this study, patients who are MRD positive, here we're talking about a level of 0.1%. We have much better, more sensitive MRD assays now, but who are MRD positive after 3 or more cycles of intensive chemotherapy were treated with blinatumomab. The vast majority of patients, almost 80% of patients, achieved an MRD response, and you can see that those patients who achieved an MRD response had better outcomes than those who did not, which is not particularly surprising. I think the one big question is, well, what do we do with a patient who's MRD positive, who we give blinatumomab, they become MRD negative, do we need to send them to transplant? And we may have different opinions about that perhaps on the panel, which may come out in the Q&A or case discussions. Here's some data just if we look at the outcomes of patients on the left, those patients who were transplanted, those patients on the right, those patients who were not, stratified by whether they had an MRD response or not. So obviously the patients who have a good MRD response do better than those patients who do not. That's true whether or not they went to transplant or not. But for me, if I try to superimpose those curves, the patients who are MRD responders and went to transplant or not, they look very similar. That being said, transplant for a patient, transplant will reduce the risk of relapse, right? However, it introduces some risk of transplant-related mortality, and in the end, you can see, I would argue that the survival may be similar, but this is definitely an individualized decision, and we consider the baseline cytomolecular features when we're making these decisions, and some of these patients will send a transplant, and some of these patients will monitor closely, particularly now that we have these high-sensitivity NGS MRD assays. We can monitor them very carefully, and I think we can feel more confident in our decision about not transplanting if they're being monitored. Okay, so already discussed a little bit or alluded to the E1910 study. So this is a really important study that led to the approval of blinatumomab in the frontline setting as consolidation regardless of MRD. So just to go over the study schema a little bit. So this was using a pediatric-inspired regimen, so an asparaginase-based regimen in patients with newly diagnosed Philadelphia chromosome negative B-cell ALL. They were treated with induction chemotherapy. In this case, their induction is 2 cycles. And then 1 cycle of intensification, just based on the regimen. Patients who were MRD positive, they went to blinatumomab as standard of care. But those patients who were MRD negative, this is at a level of 0.01%. So not really the high sensitivity NGS, but something more equivalent to what we typically use with flow cytometry. Those patients who are MRD negative were randomized to either receive blinatumomab as part of their consolidation or no blinatumomab. So no blinatumomab, they just continued to get their standard chemotherapy. If they were randomized to the blinatumomab arm, they received the same amount of chemotherapy as consolidation, but also a total of 4 cycles of blinatumomab integrated into their consolidation, and then maintenance chemotherapy thereafter. And so here are the data, which I think are really quite dramatic. I think one thing that's important to note, that these are only the patients who became MRD negative and then were randomized. So this is not intention to treat from the very beginning of therapy. But that said, those patients who were MRD negative and received a consolidation that integrated blinatumomab had a 3-year survival of 85% versus you can see 68% for the chemo only, and unfortunately the Kaplan-Meier curve continues to have events even after that 3-year mark. So I think a really dramatic improvement with blinatumomab, and I think these data really solidified it as the standard of care for patients as consolidation for these patients. I think a couple subgroup analysis I think worth noting. So this was a pediatric-inspired regimen, and it did enroll even some older patients. For the patients under 55 years of age, which is typically where we would be considering these types of regimens for, look at the excellent outcomes for blinatumomab consolidation for these patients, right? So that's where you saw really the most significant benefit of blinatumomab. For the patients 55 years in age and older, it wasn't as clear. I would argue, it was not statistically significant, but I would argue that you can see what looks like a plateau of the curve. That certainly looks higher with the blinatumomab, but it wasn't as dramatic. Now, also one question comes up, well, do I need to use this for all my patients? What if they already have favorable risk disease? Do I still need to give them blinatumomab? They were doing well with chemotherapy alone, and the data suggests that, well, not so great, I guess, right? So if you integrate blinatumomab for these patients, well, actually in this case, the long-term survival was 100%, which we don't see very often. And with chemotherapy, maybe about 65%, which I guess isn't that bad, but we want to cure these patients, right? And so clearly, adding blinatumomab is better than not, even for those patients. And then we saw a very similar magnitude of benefit for the patients who had adverse risk cytomolecular disease. So the point is that, blinatumomab really should be used regardless of the underlying cytomolecular disease, really for patients who, whether they're MRD positive or MRD negative. So, that was the E1910 data. They used a, backbone regimen that is not commonly used, I would say, in most clinical practices. At MD Anderson, we've explored blinatumomab with hyper-CVAD in Philadelphia chromosome negative B-cell ALL. So this is the initial publication. We have more patients treated now, but the initial publication was 38 patients with Philadelphia chromosome negative B-cell ALL. We added blinatumomab to the hyper-CVAD. We typically give 4 cycles of hyper-CVAD, 4 cycles of blinatumomab, and then they move to a maintenance phase, which is POMP alternating with blinatumomab. You can see here that patients who receive, hyper-CVAD and blinatumomab, the 3-year overall survival was 81%. And when we stratify it by basically adverse risk or, high risk or lower risk disease, those patients who had high risk features still had a 3-year survival of 76%, and those patients who did not have a high risk feature had a 3-year survival of 88%. Important to note, compared to the E1910 data I showed you before, this is intention to treat. This is from the day that they walk in and we start them on treatment, as opposed to the E1910, which is only those patients who achieved MRD negativity after the initial induction. And then here, this is data from Dr. Aldos, and I think one of the questions, of course, is I know, at MD Anderson we use hyper-CVAD in a lot of community and academic practices as well, but a lot of practices prefer to use pediatric-inspired regimens, and the most common one used in the U.S. is the CALGB 10403. And so this is just to show the feasibility, really, of integrating blinatumomab into that regimen. 31 patients treated. You can see where the blinatumomab was integrated, 2 cycles after the consolidation, and then 1 cycle after interim maintenance, 1 cycle after delayed intensification. Median age of this population, 31 years of age, and you can see that survival curve, which is excellent in this certainly younger population. But it shows the feasibility of adding this into a CALGB 10403 regimen, and certainly excellent outcomes. So I think it provides very nice data for those who prefer to use this type of backbone, and how best maybe to integrate blinatumomab into that. And so also, blinatumomab is also commonly used in older patients. So I mentioned in the E1910 data, subgroup analyses didn't show as clear of a benefit in the patients 55 years of age or older. There is a study that's ongoing, which is the Golden Gate study, which is going to be very specifically looking at this older population with a lower intensity regimen with blinatumomab to clarify the role of it there. That said, many groups have sort of done studies looking at blinatumomab integrated into older patients in single-arm studies. These are data from MD Anderson where we use the mini hyper-CVD regimen. So it's like hyper-CVAD, but we reduce the doses of the chemotherapy, we remove the anthracycline. Initially, we added inotuzumab onto it, and then more recently, we added blinatumomab. So patients receive low-intensive therapy, inotuzumab, blinatumomab. So they're getting all of the best available, immune therapy for B-cell ALL. And here are the outcomes for patients, the older patients that we treat with this regimen. So this is for patients 60 years of age or older. You can see that with this combination of 5-year progression-free survival, 44%, 5-year overall survival, 46%. A lot of the historical data, if you use like a hyper-CVAD or even other dose-reduced regimens for these patients, 5-year survival historically was closer to 20%. So I would argue that this looks like to be a significant improvement compared to at least that standard, although I know that there are a number of other groups who have used other sort of backbone regimens for these patients. I just want to highlight that there are some, for these older patients treated with these types of regimens, we still struggle with these patients, even with reduced intensity therapy. As I mentioned, this was a study for patients 60 years of age and older, but we can see that within that older population, stratifying them by age does impact outcomes. So you can see, the 5-year survival for patients who are 60 to 64 was, I think quite good for this older population, around 63%. But then it drops dramatically to only 30% for those patients who are 70 years of age or older. And a lot of the challenges of these patients is actually just delivery of the treatment. Even though it's what we call a low intensity regimen, these patients can still die from myelosuppression related complications, infections, et cetera. And we still struggle for these patients which is very common in this older population who have high-risk cytogenetic or molecular features. If patients don't have a high-risk cytomolecular feature, they don't have, low hypodiploidy, complex cytogenetics, TP53, then their 5-year survival is, 55% versus only around 20% still for those patients who have a high-risk feature. And so then I think lastly, just to talk about these chemotherapy-free regimens that are being explored, and I would argue, becoming a standard certainly in the US for patients with Philadelphia chromosome-positive ALL. We have data from our colleagues in Europe and Italy with dasatinib and blinatumomab, so completely chemotherapy-free regimens for patients with newly diagnosed Philadelphia chromosome-positive ALL. With a 4-year survival of 81%, which is really excellent considering that that's kind of what we saw even with intensive chemotherapy with, potent TKIs like ponatinib, for example. And then at MD Anderson, we've been exploring ponatinib and blinatumomab, and here we've reported a 3-year survival of 89%, and we have updated data that we're going to be presenting at ASH this year as a poster. And so one potential algorithm is and this is what we do, for example, at MD Anderson, we treat all of our patients regardless of age with a chemotherapy-free regimen, blinatumomab plus a TKI. We prefer ponatinib for these patients. If they achieve deep MRD negativity, and we're really looking at the NGS MRD, not really at we do test for the PCR for BCR-ABL, but we really rely on the NGS MRD to make our decisions. If they achieve good MRD clearance, we just continue them. We give them their 5 cycles, continue on to maintenance TKI. If they're MRD positive, then we do consider them actually for CAR T-cell consolidation, and then consider them potentially for stem cell transplant, although that's a very uncommon that we would have to do that. And with that, I will conclude, and then
Thank you, Nick. Good morning, everyone. So I'll be discussing about the next wave of bispecific antibodies in ALL. So as blinatumomab has become the standard frontline therapy for newly diagnosed B-cell ALL, and this can range from blinatumomab in older patient as a frontline to the younger patient with Ph-negative ALL as a consolidation, to newly diagnosed Ph-positive ALL, I think the emerging question comes as what therapeutic options we will have once the patient relapses after frontline blinatumomab. And when patient relapse after frontline blinatumomab, there are 2 scenarios. Either relapse will be still CD19 positive or CD19 negative, and the reality that the majority of relapses will be still CD19 positive. And for these patients, they tend to be amenable for additional CD19 target therapy, and this can range from CD19 CAR T-cell therapy to one of the newest bispecific CD19 target therapy. I think the more challenging situation is the CD19 negative relapse. And in one study, we actually look at City of Hope, how many patients they relapse with CD19 negative disease after prior blinatumomab. We looked at patients who responded to blina, then they relapse. We had around 30% of cases were CD19 negative disease. So I think it will be an emerging problem as we're using more blinatumomab early on. We will face more patients with relapsed CD19 negative disease. And this opened the door for new targets in B-cell ALL. There are different candidates. I think the most common used one is CD22, but there are maybe other options, CD20, BAFR, other targets as well. So sub-Q blinatumomab is one actually of the promising CD19 T-cell engager. And it's not merely an alternative kind of route of administering blinatumomab. Now, the drug was developed to aim to achieve kind of higher exposure of the drug compared to the IV blinatumomab. At the same time, it is potentially a more convenient way of actually delivering the drug. Rather than the patient be on continuous IV infusion, it is given as sub-Q, but it is frequently given, up to 3 times a week. So in addition to that, I mean, if you look at the PK data for sub-Q blinatumomab, it's actually more favorable than IV blinatumomab, where you can see the rise in exposure more gradual than IV blinatumomab, and you're able to achieve higher levels and also longer half-life than IV blinatumomab. So in the phase 1/2 study in patients with relapsed refractory B-cell ALL, they were treated with sub-Q blinatumomab, and 2 doses were compared head-to-head. You have the lower dose, where the sub-Q blina is given at 250 mics daily for the first week, and once you reach the second week, it's given 3 times a week at higher dose, the 500 mics each dose. And there's the higher dose where the sub-Q blina is given at 500 mics daily for the first week and increased to 1,000 mics 3 times a week after the first week. And you can see that actually both doses highly effective. I mean, the CR/CRh was 75% with the lower dose and 79% in the higher dose, and the majority of responders were MRD negative. And this is actually compared favorably to the IV blinatumomab in the TOWER study, especially considering you have more patients who fail other novel therapies, blina, CAR, intuzumab, and more heavily pretreated patients. And sub-Q blina activity was regardless of prior therapy. You can see that the CR/CRh rate was high across all the previous therapy. For patients who get exposed to IV blinatumomab before, this number was 65%. For patients who had prior CAR T-cell therapy was 89%. I think this is not 85%, 90%. Was, I think, 65%. 64%. Patient prior intuzumab was 69%, and those who had prior transplant was 56%. And Dr. Japour and colleagues have an updated abstract, this ASH, to look at longer follow-up for these patients. And with longer follow-up, you can see patients who achieve CR/CRh. Now they have a median time for response more than 18 months. So it is active. It can potentially produce durable remissions. Now, the problem, as we increase in the dose of sub-Q blina with more drug exposure, the expectation you will have more toxicity. Dr. Short shared previously that for grade 3 CRS across the different study, it was almost 0. And with the sub-Q blina, we see as high as 20% grade 3 CRS. Usually it happens early when you start the drug. And the resolution, median time for resolution is within 5 days. The same thing with ICANS was in the range of 2%, 2 to 3% grade 3 or higher. And here we're seeing up to 17%. But the reality, this is manageable, usually happen early, and with right management, usually it resolves. With less frequently, it will come back in the future. But we're seeing also neutropenia grade 3 and 4 in the range of 22%. Now, based on the efficacy, tolerability, and the PK data, the decision was made to use the lower dose as the recommended phase 2 dosing. And some key points on sub-Q dosing is the drug is given 4 weeks on, 1 week off. And before we start, patient received dexamethasone as pre-medication. And in the first week, sub-Q blina is given daily, then moving to the second week, and after it is given 3 times a week. And in the study, they admit the patient for the first 12 days. So it is a promising drug. Now, people can argue, how practical is it to come to the clinic 3 times a week versus once a week for the IV blinatumomab? But again, at least you're not having the continuous infusion with IV blinatumomab. Now, the second promising drug, it's a CD19 bispecific antibody, is servatimig, which is used to call AZD0486. There are a few things unique about this T-cell engager. It has a low affinity CD3 binding site, leading to reduced cytokine release, so less toxicity, and you're able to actually increase the dose to a more effective dosing. It has a high affinity heavy chain, only CD19 domain that ensures strong and specific attachment to CD19, and also it actually helps in tissue penetration. It also has silenced IgG4 Fc tail, and this prolongs the half-life of the drug. It's in the range of 8 to 15 days, and this supports the administration every 2 to 4 weeks. So this can improve the practicality and the convenience for the patient rather than having frequent infusion, continuous infusion. It's a 2 hours infusion every 2 to 4 weeks. So the CIRUS study is the phase 1/2 study that is ongoing, actually, and currently evaluating the single agent servatimig in relapsed refractory B-cell ALL. And these are the key eligibility criteria. It allows patients 16 and above with relapsed refractory disease, and they have to have CD19 expression, but there's no specification about how much expression you have. As long as you have expression, you're allowed to be enrolled. And it allows prior CD19 target therapy. Patient could have prior blinatumomab, prior CD19 CAR T-cell therapy, and still eligible. And the primary endpoint is safety and tolerability, but key secondary endpoints, efficacy, BK, immunogenicity. And MRD is being checked centrally with clonoSEQ. So to kind of decrease the toxicity, mainly CRS and ICANS, the CIRUS study incorporates 3-step-up dosing, where in the first cycle, the dose starts at low dose on day 1, escalate to on day 4, then again on day 8, and the target dose is given on day 15. But afterward, the drug is given every 2 weeks. And actually, for patients who respond really well with clonoSEQ negative for 6 months, you're allowed to go to once-a-month dosing. So there were 2 step-up dosing were tested in the phase 1 study. There's a lower one and a higher dose. These are the doses for each one. And in the EHA this year, we reported on the first 3 dose levels we tested, and the dose level were referring to the target dose. So dose level 1 was 2.4 milligram, dose level 2 was 7.2, and dose level 3 was 15 milligram. This is the patient characteristics, the one we report in EHA this year. And the median age was 56. You have 20% who are pH positive. And these are heavily pretreated patients. The median prior lines of therapy was 3 lines, and you have patients up to 9 prior lines of therapy. What's unique about the study is the majority of patients, they had prior CD19 target therapy, 61%. You have more than half patients, they had prior blinatumomab. Third of the patient had prior CD19 CAR T-cell therapy. You have quarter of patients who get exposed to both blina and CAR T-cells, and you have patient, maybe third of the patient who had prior transplant. And another thing is what we know from blinatumomab IV, there is a correlation, inverse correlation between disease burden pre-starting the treatment and between the response to blinatumomab. So the higher disease burden, usually defined as 50% plus in the bone marrow or more, they tend to have low response. And in this study, we have 2/3 of the patient considered to have pre-treatment high disease burden. So from toxicity standpoints, we see that the drug was well tolerated and focusing on CRS and ICANS, which expected with any CD19 target therapy. If you look quickly, you can see that there were no grade 4 CRS or ICANS, only 1 case of grade 3 CRS, only 1 grade 3 ICANS. And the way we divided actually the toxicity here is based on the step-up dosing, compare the lower dose versus the higher dose, and the toxicity after the target dose. So you can see that maybe you see a more CRS and ICANS with the higher step-up dosing compared to the lower step dosing, which we haven't seen any ICANS. And if you look at the target dose, I mean, it doesn't seem to be dose-dependent. The patient who received the higher dose didn't have any CRS or ICANS starting on day 15 after they received the target dose. I mean, what's important, I think, in the CYRUS study, besides it is safe, it is highly effective. And these are the data where we show that patients have dose-dependent enhanced, actually, activity of the drug. Patients who were treated with dose level 1, they have 46% CR/CRI. This increased to 58% with dose level 2, and for the highest dose, it was 83%. And all patients who responded on days level 2 and 3 were achieving actually MRD negativity. And we only saw relapses at the time of reporting the data in EHA, only in dose level 1. And I think what's more exciting is the activity in patients who had prior CD19 target therapy, especially with the higher doses. You can see patients who had Blena, CAR, and Intuzumab with the higher dose, they all responded to treatment. Another exciting thing is we know that extramedullary disease at the time of the treatment for Blena confirmed resistance. These patients, they tend to not to respond. We see actually higher frequency of extramedullary relapse after blinatumomab. And here we had 5 patients with extramedullary relapse, and we will have more patients in this ASH. 4 out of these 5 patients actually responded to Survatimig. So that was another exciting point. All the responses happened after the first cycle, and using central clonoSEQ, the MRD negativity for responders was 81% at the level of 10 to the minus 5, and it allowed patients to be transitioned to allogeneic stem cell transplant and DLI, and the 6-month duration of response was 86.5%. And this is an updated data from this ASH. It's in a poster on Sunday, where we have more patients treated at the higher dose, and we showed that actually the response still consistent, 82% in the 17 patients treated at 15 milligram. And with that, I mean, it's an exciting drug because the high response rate and the convenience of giving the drug, so there's a lot of talk how we can bring it to frontline therapy. Another exciting drug, it's a T-cell bispecific it's a T-cell engager that targets CD19 is the MK1045. And it's a humanized IgG4 with Fc domain and knob into whole design, where it's designed to actually reduce the toxicity and prolong the half-life. So this drug is given in 2 step-up dosing in day 1 and 8, and the target dose is reached in day 15. So it is given weekly afterward, and it is a very promising drug. So it is, let's see the next slide. So there is an abstract, this ASH, it's an oral presentation presenting data on 73 evaluable patients, and it is based on the phase 1/2 study that's still ongoing. And the phase 1/2 study, they tested 10 doses, and they haven't seen any DLT, and they haven't reached the maximum tolerated dose. 45% of patients, they developed CRS, but grade 3 CRS was only 3%, and there was no ICANS. And we can see the response rate is very encouraging, especially with higher doses. For patients who receive 60 milligram target dose or higher, the CR/CRI was in the range of 83%. The study was conducted in China, so they have maybe less patients who were treated previously with blinatumomab, CAR T cells, and Intuzumab. But the majority of responders were MRD negative as well. So this is for CD19 target therapy. I mean, as I mentioned, the problem, it's CD19 negative disease, and we really kind of looking for other target therapy. One of the promising targets, CD22, to develop for T-cell engager, as we have excellent experience with ADC target CD22, we have CAR T-cell target CD22. So there are some preclinical data suggest that T-cell engager that targets CD22 seems to be active in vitro and vivo, and possibly can be synergistic with blinatumomab as well. But you can move another step ahead, where you can have the trispecific T-cell engager, where you can target CD19, CD22 to prevent relapse in general that can be CD19 negative or positive. But we're still looking for other targets as well. I think there is a lot of experience with CD20 bispecific antibody in non-Hodgkin lymphoma, and we're trying to get some interest to use these drugs in ALL. Unfortunately, the market's smaller, so we're seeing some resistance from pharma companies to support studies with CD20 bispecific in ALL. But there are other targets. I mean, we have a study where we actually tested BAFF-R where we're seeing responses in B-cell ALL, and there are in the market some BAFF-R bispecific T-cell engagers as well. So it's an area of unmet need that we need actually more study as we're going to see more CD19 negative relapse in the future as we're using more blina frontline. And with this, I'll give the microphone for the chair. Nicola, please.
Yeah, thank you very much. Yeah, before we start with the case discussion, I would again like to encourage you to post your questions into the app so that we have, in the end, we will also have the opportunity to discuss questions from the audience. Now, let's move ahead with a few cases which we have prepared together to highlight some essential decision points in the use of these new compounds in the management of ALL. And the first case is a 50-year-old male patient with newly diagnosed B-ALL. And yeah, it is age already a little bit at the limit for intensive therapy. The patient has, in addition, IDH-CRLF2 rearrangement and received hypersievert induction and has a morphologic CR. I assume hypersievert induction is 2 cycles?
We can consider it as 2 cycles for this case,
okay.
yes.
Yeah, and at the end of this induction, where most of you thought it was the most relevant time point for MRD-based decisions, the MRD was negative below 0.01% by central flow. So flow, another word which you have to consider because we have different methods for MRD testing. Now, therefore, the first question would be, what is the ideal plan to guide post-induction management based on MRD testing? So would this be your approach to assess MRD after the induction and decide then?
Yeah, so I mean, all of this really depends on which regimen you're using, and so you have to kind of look at the published regimens and kind of when MRD is assessed and maybe where decisions are made. So if you follow something like the E1910 data, you can kind of backbone, you can use that. For hyper-CVAD, we do assess after every cycle, or at least until they become MRD negative. We don't necessarily make a decision right after this induction time point. However, but typically we're really relying on the NGS MRD. So in the US, we're using the clonoSEQ assay. If patients after this time period, if we say 2 cycles, so like part 1A and part B, if they're still flow positive, we do like to start the blinatumomab at that time to kind of move it up, because we saw in some of the patients that had suboptimal responses, previously we saw patients who were relapsed before they could get to the blina. So if they're still flow positive at this time, we would sort of consider that. For a patient like this who's MRD negative by flow, we continue with the hyper-CVAD and then integrate the blinatumomab as standard of care now as consolidation. But really what we're interested in, I mean, the flow is nice, and I mean, it's a nice response, but what we really want to see is the NGS MRD. We want to see what are the dynamics of it, when does that patient become negative, and that'll sort of help to decide on consolidative therapies such as stem cell transplant, et cetera.
So this early MRD negativity would be a sign of a very good response, but you want to have confirmed it with a more sensitive method afterwards.
Yeah, I mean, I'm happy with the response, but ultimately, the patient really needs to be NGS MRD negative. And I think the question is, when does that need to happen? Yeah. I think for a patient like this who has some high-risk features, like the CRLF2 rearrangement, we've published data on this that that patient, to have good outcomes, really should have really rapid clearance, right? We'd like to see within 1 to 2 cycles them to be NGS MRD negative, or else our data suggests that those patients benefit from transplant. So that would be a patient we'd consider for transplant. Even with this alteration, which is considered to be high risk, if they really achieve rapid clearance of NGS MRD, we don't really necessarily send them to transplant. We proceed with the rest of the treatment, give them blinatumomab, monitor with high sensitivity NGS MRD, and try to spare them a transplant in first remission.
Thank you. So Ibrahim, in your setting, you use a pediatric-based regimen?
So we tend to use pediatric up to age 54. So I mean, typically we'll give the CLGB 10403, and very similar to what Nick mentioned. I mean, this is a high-risk disease with pH-like, with CRF2 rearrangement, so we're kind of very aggressive. The one we spare from transplant is the one who cleared clonoSEQ after consolidation, which is the second cycle. But if they have a high MRD after induction, that will be another reason to actually take to transplant. Typically, after we do consolidation, then we give blinatumomab. Now, if he achieve, MRD flow after induction, then clear the clonoSEQ after consolidation with the integration of blinatumomab, we haven't been actually transplanting these patients because they have good response.
Mm. And what about the MRD method? Do you think in the United States everybody uses no clonoSEQ, or is it readily available everywhere?
I think
we're easy to establish in the standard of care?
I think we're using it more and more. And the truth, most of us were using both flow and clonoSEQ together to also kind of to look at the phenotype of the disease, or we're using more blinatumomab. But we're seeing more and more people using clonoSEQ. It's a more sensitive test.
If you think about the ECOG 1910 trial, there the decision was made on MRD negativity after two-phase induction and one consolidation. But I think it's also a reasonable approach because the patient have then received most of the drugs that are available. Now, hypersievert, you have repeat the same cycles, but in the pediatric regimen, maybe it would be better to at least give some high-dose methotrexate or high-dose RSC before making the decision or based on MRD. What do you think about that?
In the CLGB 10403, they use Cabezi methotrexate, not high-dose methotrexate. So the methotrexate come after the consolidation. So typically we make the decision before we reach there, but they receive the consolidation, which is a completely different drugs than the induction. Besides the vincristine and the aspergillase, you have the low-dose cytarabine, the Cytoxan, the mercaptopurine as well.
Yeah, I think we have not a lot of data now on making decisions, for example, in specific subtype, like here, the high-risk molecular subtype. For example, the Italian study, they showed a very good response to blinatumomab, but then the patients were not transplanted and had still a very poor outcome. So it's very important to gain more data on that prospectively.
Yeah, what I say, Nicole, from the JIMEMA study, I think blinatumomab, it's very effective in clearing the MRD and pH-like, but I think to achieve excellent outcomes, you have to achieve MRD negativity by chemotherapy before blina, and blina supplement the outcomes furthermore.
Yeah, that is the point. So that's something really too important to mention. So thank you for that. That rendering MRD negative by blina is not the same like rendering MRD negative by chemo.
Yeah.
Yeah, and I would agree with that, and I would say maybe it perhaps depends a little bit on the underlying cytomolecular. I think our data suggests that for patients with standard risk disease, even if they have a little slower MRD clearance and then they clear after blina, they still do very well without transplant. But if a patient has a high risk cytomolecular feature, and then they're also showing that they're less chemosensitive, right, based on the MRD after chemo, then maybe just giving the blina after that is not as helpful to overcome the outcomes. Of course, now one other thing that we have is that we have NGS MRD to look at after blina. And also we've shown that actually those patients who become NGS MRD negative after the first cycle of blina, not surprisingly, they do better than those who are MRD positive, but they really have excellent outcomes as well. So having this more sensitive tool kind of changes, I think, a lot of these calculations that we had before when we were just relying on a sensitivity of 10 to the minus fourth, 0.01%.
Okay, so let's now look into the same patient with a slightly different angle. I think we discussed already about the situation which is represented here. So the patient is still positive after this initial induction. And I think the first question is very clear, that this has a higher risk of relapse. But what would be the next step? Here is the decision much more difficult on a transplant. So certainly blina, I assume. What do you think?
Yeah, so I mean, we would give this patient blinatumomab. I guess as I mentioned before, we typically, again, our regimen, if we're using the hyper-CVAD blina regimen, is 4 cycles of hyper-CVAD for blina. That said, if a patient let's say after the 2 cycles of hyper-CVAD, they're still flow positive, we do move the blina up, so we might give 2 cycles of chemo, 2 blina, 2 chemo, 2 blina. I think the big question is this information enough to say that this patient needs transplant? Certainly they are going to get their blinatumomab, right? That's going to be standard. I think that's where the data are not as clear. I do think that, the patient has a high-risk feature, the CRLF2 rearrangement. They didn't seem to be as sensitive to chemotherapy as we would have wanted. I think it'd certainly be a very reasonable to send this patient to transplant. In our practice, honestly, what we would do is we would also move the blina. Let's see if they clear after deep MRD negativity after 1 cycle of blina, and then with really close monitoring. And then also, we have, for example, we do CAR T-cell consolidation usually on a clinical trial, so we're trying to avoid transplant. But in the absence of that, I do think that transplant would be a reasonable option for someone who has a high-risk cytomolecular feature, who's not particularly chemosensitive, as shown by the MRD positivity at this time point.
Well,
yeah, I agree. I mean, this is high MRD in the context of high-risk genetics, and usually for MRD more than 0.1% after induction, this patient we allocate to transplant after we clear it with blinatumomab.
And do you think in the setting, if you decide so early on a transplant and blina, and even 2 cycles blina, does the patient receive enough CNS active compounds? I'm a little bit worried about.
I mean, we tend to give IT chemotherapy with blina, and sometimes if we feel we haven't given enough IT chemotherapy, sometimes we continue after transplant, which again, I mean, it's very debatable how much you can help the patient by giving both transplant IT chemotherapy. Yeah, but we try to kind of squeeze as many IT chemotherapy as possible for transplant. Usually we aim for at least 6 to 8 before transplant.
Yeah.
Oh, and I would just say, like, even if we were going to transplant this patient, which again, we try alternative approaches, but we have access to these, CAR T-cell studies, for example. But, we still don't try to rush into the transplant. So, for example, we watch the MRD as long as it's declining. So for this patient, for example, let's just say I'm planning to transplant this patient. Well, after this, and I move them to blina, and then the MRD either becomes negative or declines, I give them the blina. Sometimes I will even go back and give another cycle or 2 of chemo, and then also more blina. Like, I want to maximize their therapy and get them in the deepest remission possible prior to transplant. Again, closely monitoring. You don't want the case where they start to come back, the MRD starts to rise, but I think in these patients, like a patient with this kind of phenotype, as long as the MRD is declining with each subsequent cycle, I think that we like to kind of not rush into the transplant, and that gives us time to give the IT chemotherapy, get them in the deepest remission possible, and then send them to transplant in a clonoSEQ negative state, which we know has better outcomes.
It's a difficult individual evaluation, I think, because adding more chemo can also add more tox, like severe infections. So it's a high kind of balance. And often the experience is the patient has blina, they somehow get in a better general condition. It's also important for a good transplant outcome. So it's complex, yeah. So let's go to the next patient. This is a young patient here, and we come here now to the relapsed refractory setting. And just what Ibrahim was discussing, patient had upfront blina and chemo, and then she was already MRD negative, but then relapsed CD19 positive 18 months. Maybe such a patient with the initial high-risk molecular setting. So what is the next step here in your advanced hospitals and maybe in the general standard of care?
Yeah. I would say it depends on the scenario of the relapse. I mean, if the relapse is extramedullary disease or concurrent extramedullary and bone marrow, I tend to favor CAR T cells. If it's a low level of relapse where the disease burden is low and the patient has a donor, I may just give blinatumomab and proceed with transplant. Sometimes for proliferative case, I may give intuzumab for cytoreduction. But I tend to avoid it if the ultimate plan to transplant. Again, me and Nick, maybe we may not agree if this patient will need transplant if they achieve clonoSEQ negative. But our standard is still actually to transplant every relapse patient after achieving CR2. So our goal is to transplant. It is what's the fastest, easier way to kind of achieve remission so we can have a safe transplant in this patient.
Additional thoughts?
Yeah, I think similar. It is an individualized decision. I mean, this patient's particularly young, and so could probably do well with transplant. That being said, we still often will avoid it and try to avoid it in these patients. So for a patient like this, who particularly, okay, so this patient did get blina in the frontline setting, so that's something to consider. But this relapse is over a year after their remission. And we've looked at this, we've looked at the relapsed refractory patients, and of course others have looked at like the duration of response, but when we give them, what we consider our optimal therapy, I talked about for the older patients, the mini CVD in blina, like we want to give this patient, young patient, give them everything. So we would reinduce them with like a mini CVD in blina. Those patients, if they can achieve MRD negativity early and they had a long first remission, which we're talking about just over a year, those patients do very well without transplant. Now, we would give the mini CVD in blina and then a CAR T-cell as a consolidative approach. And I think that, again, monitoring NGS MRD, they need to become, rapidly NGS MRD negative with these approaches, and then we would avoid transplant for that. If this patient is having suboptimal response to the mini CVD in blina, then I think, I would, certainly be more worried about them and consider them more strongly for transplant.
Okay. Good. So this is, again, some additional questions, particularly whether this patient would be a candidate for a clinical trial, I think.
Yeah, I think it's very reasonable.
Very clear answer.
Yeah, I mean, I kind of mentioned I would re-challenge with blina, but it's the truth, I don't re-challenge frequently. I mean, I tend to either move to CD19 CAR T-cell therapy, or if we have one of the CD19 novel engagers, I mean, I tend to choose that if we have a donor. I mean, if you have a donor, rather than waiting until you collect and make the CAR T-cells and give the CAR T-cells, these are off the shelf and available immediately. They already show an actually high response rate in patient who was exposed to blina. So it's a very reasonable approach.
Okay. Good. I think we discussed these cases sufficiently, so I don't want to summarize them again. Yeah, again, I want to mention the HealthTree Foundation, which does really important work for the patients, and also, again, to scan the QR code. Now, we have now time to have a few questions from the audience, and I hope that you have some questions. I would see them here on my iPad. Not iPad, something.
Turn it on.
Yeah.
Oh, you have it? Okay.
So far, there is no question here, so let's use the time.
I think we have a question. Yeah, go ahead.
Please, great that you are even here in the room. Let's just take a microphone, please, so there's the audience also online.
My question is for those patients who receive frontline treatment with blinatumomab as consolidation for MRD negative disease. We know the previous trial from ECO-CAGRIN that gave also, it was the registration trial. Now my question is, do we have data that those patients who relapse after this kind of treatment, what is the rate of CD19 negative disease? When they receive it, when they receive blinatumomab for MRD negative disease. Do we have this data?
I don't think we have this data. I mean, I haven't seen this data, the truth. But, we looked at least from our center, well, disease burden when the blinatumomab was given, does it impact CD19 negative relapse? And we haven't seen actually a different signal that between patient treated for MRD positive, MRD negative, then relapse or relapse refractory disease. But I'm not aware of the data. I'm not sure, Nick or Nicole.
I can say for our patients treated with frontline, I don't think we looked at it specifically in the pH negative. I can speak to the pH positive, which I know is a different context, but we're still talking about frontline blina. All of our patients who we treated with frontline blina-based combinations, blina plus TKI, all of them are CD19 positive at relapse. My just general impression from our experience of the relapses is that the rate is quite low. I mean, we had probably, there's a lot of data for relapsed refractory CD19 loss. And I know that you published on this as well. Maybe 10 to 15%. What was the overall rate in your?
30% for responders who relapse. I know this is different between us and you guys. I think you're in the range of 10%.
Yeah.
It could be the genetic subtypes we see is different than MD Anderson. But we haven't seen that difference.
I mean, this comes maybe the type of using blinatumomab has a role. And most data come from the relapse refractory. And if you give one blina after another, the pressure to CD19 is, of course, very strong. So if you have interim chemo, that's a total different setting, maybe.
Yeah. I think the genetics also matter. We have seen TP53, especially, they tend to relapse more with CD19 negative disease. Okay. But it could be also like what sequential therapy the patient receive.
Yeah. Okay, so I have some questions. Any other questions from the audience? No? So then there's a question.
There is a question there, Nicola.
What? I don't know.
It's right there.
Please come just to the microphone.
Hi, I'm Sanjay from UK. Are you seeing an increased incidence of CNS relapses in these patients at all who are having blinatumomab?
As consolidation?
As a whole, basically, because I think you are adding blinatumomab to your therapy, but some people are substituting their consolidation therapy as well?
Not yet. I mean, we're not substituting. We're just adding for now. We may be taking part of the pump maintenance. It's become shorter as you incorporate blinatumomab as part of consolidation. The truth, we don't have a lot of data about relapse after frontline blinatumomab to see what's the rate of CNS relapse in these cases. But we're still maintaining at least the same number of IT chemotherapy. And we tend to give actually IT chemotherapy with each cycle of blina. So if anything, they're receiving more actually IT chemotherapy.
And so I would say also, like, if you're doing like an E1910, or I guess as you did with the CALGB10403 integration, you're really just adding blina right to the backbone. With the hyper-CVAD, we actually did reduce the hyper-CVAD, which was previously 8 cycles to 4. So the blina was replacing the last 4 cycles of hyper-CVAD. In absolute terms, the relapse rate is lower. Like, we've looked at that, it's definitely lower than it was with hyper-CVAD, which is what you'd expect based on the E1910 data. The relative proportion of CNS relapses did seem like it increased a little bit. And so we actually increased our prophylaxis, which was previously with hyper-CVAD and pH negative, 8 doses of IT chemo. We increased it to 12 when we kind of reduced the total amount of chemo. Similar to what we did in, for example, pH positive ALL, when we moved to chemotherapy free, we see still a very low rate of relapses in absolute terms, but we have an increased relative risk of CNS relapses in patients treated with chemotherapy-free regimens. So we increased our IT chemo from 12 when we used to give with hyper-CVAD to 15 with the blinatumomab regimen. So I do think that if you do reduce chemotherapy, you are going to probably increase your risk of CNS relapses, and the blina is not good for preventing or treating CNS relapses, so that is something to consider.
But there's a question also whether irinotecan is really enough. So if I remember correctly, didn't you introduce chemo again for patients with high white blood cell count?
So we did for the patients with the high white count. So if we're talking about pH positive, if they have a white blood cell count over 70,000 at diagnosis and we give them a chemo-free regimen, those patients had the highest risk of relapse. So we did go back to add 2 cycles of high-dose methotrexate and cytarabine. I am not convinced that that is the right way to go for those patients. When we look back at our other data, actually with hyper-CVAD, ponatinib, before we added blina, those patients had a higher risk of relapse there as well. So I don't know if the chemotherapy is necessarily going to be the answer. What we do now for those patients is actually we do CAR T-cell consolidation. Again, we have a trial for that. And I would like to still move away from the chemotherapy for the pH positive, even for the high white count. But I think the principle is important, is that if you do reduce the chemo, you will, even if you have a very effective systemic drug like blinatumomab, you can increase the relative risk of CNS relapses, so you have to be careful. And yes, I don't know, there may be a limit to what we can accomplish with the IT chemo, but certainly increasing the dose may help.
Further questions from the audience? Then maybe we can just discuss one question here from the virtual audience: how to prevent ICANS and how to react.
For bispecifics?
Yeah.
Yeah, I mean, I think with the newer bispecifics, we're not seeing that frequent ICANS as we see with maybe sub-Q blena is an exception. Again, I mean, it is manageable. It tends to be brief with dexamethasone. How to prevent it? I mean, I can share my experience from the sorvatimig. I mean, if the patient develop maybe ICANS with early doses, I may add more dexamethasone and sometimes give it for 2 days with the subsequent doses because it tends to happen early, maybe after the second dose, after the one that develop ICANS. Cytoreduction is a preventive approach to reduce ICANS. Seems, I mean, the higher the disease burden, the more likely you will have ICANS. So cytoreduce before actually starting these bispecific antibodies may help as well. We haven't been using Kibra for bispecifics. We use it, the anti-seizure medications, we use it for CAR, but not for bispecifics usually.
I mean, I'll say pretty much the same. You know, for the CRS, I think the disease burden matters. It's not as clear how much it matters for ICANS, but certainly I think treating patients with lower burden disease I think is better in general because I think it's the efficacy of these drugs is better and in general the safety. It's really about, like, we're talking about blena, which is, you know, just the continuous infusion blena. It really is not so much a prevention. Sometimes it happens and it's unpredictable. We've actually tried to look at the predictors, and it's really hard to tease out who are the patients that have it. Sometimes it's an older patient, sometimes younger patient, sometimes it's high disease burden, sometimes it's low disease burden. But it's more if it starts to happen, recognize it, hold the blinatumomab, give steroids, and then we have a lot of strategies that we do to try to still deliver the blina to that patient. So I think that's the challenge, right? So reduce the dose of blina, slow escalation, steroid tapers, and sometimes we just only go up to 9 micrograms per day of blina and stop there, and we still feel good that we're giving the patient some therapy if they're having difficulty tolerating the 28 micrograms. It's hard to say how much that compromises efficacy, but I certainly think it's better than just abandoning the blinatumomab because you're having trouble with toxicity.
Exactly. So it's also my experience that some patients they can only tolerate 9 and then still go quite well. Yeah. So is there a real contraindication to further cycles of blina? What do you think?
With neurotoxicity? You know, I have been able to restart, but I tend to give dexamethasone for a couple days as a preventive in each cycle. And I've been seeing actually good outcomes. I've been able to continue.
Yeah, I think we see a lot of referrals in community practice, or a decent number where we say the patient couldn't tolerate blina, we had to stop it, and it is challenging. But I think that I can count on one hand how many patients we've been like, we can't give blina to this patient. Usually we can give them some blina, steroid, with a steroid taper, low dose. Sometimes we do consider doing the Keppra. I don't know the benefit of it, but if it's ICANS is the issue, sometimes we try it. And I think we can usually deliver the blina.
Yeah. And what about pre-existing conditions, particularly in older patients? In all the trials we had a lot of contraindications like pre-existing CNS disease, all these things. Is that still relevant in clinical practice?
You know, we have using it in patients with prior seizures. I mean, I can share my experience. We haven't seen blina can induce a seizure again. I mean, I know that these patients were excluded from prior studies, but it is well tolerated usually.
Yeah, it's hard to say, to everyone I recommend to do it, but that being said, it is extremely unusual that we would have a patient where we would say, okay, I don't think we can give this patient blina. Again, if a patient has like an active seizure disorder and they had a seizure last week, then I would not give them blina, right? But someone who has a history of a seizure and they're well controlled on their seizure medications, I would give them blina. You're gonna admit them, you're gonna watch them carefully, you're gonna do you might even change your escalation and do it more slowly, but I can't really think of many examples of cases where we would not be able to give the blina.
Yeah, that would be quite interesting to collect some data on this because all the clinical trials were so reluctant on this topic.
Yeah, I mean, we've looked at it with CNS disease and we showed that we can deliver it safely for patients with CNS disease. We actually, even our trials, we exclude CNS leukemia as a CNS contraindication. It's not that it's good for the CNS disease per se, but you can give it as part of the systemic therapy for patients with CNS disease, and that doesn't seem to be problematic.
Okay, then I have another big philosophical question. Do you see a potential for chemo-free treatment in Ph-negative ALL?
Chemo-free?
Yeah.
I think it's possible. I mean, in older patient, I mean, I think there's the Lion study where they use intuzumab followed by blina. I think MD Anderson, they're doing the same thing for older patient. I think with the introduction of CAR T-cell therapy in frontline therapy, I mean, we could potentially patient get induced with low-dose chemo, blina, or intuzumab, blina, followed by CAR T-cell therapy as a definitive consolidation. So I think this is the future, and especially with the new bispecific antibodies seems to be active in high disease burden, that potentially can be as initial therapy, they're effective in extramedullary disease. So I think in the near future, we may see that as well.
Yeah, and I think, of course, I agree. We have to start with the older patients, right? We have to show the activity, we have to show the long-term efficacy, and then before we could even consider that. I mean, we did move pretty rapidly, I think, to chemo-free for Ph positive, which is historically this really adverse risk subtype of ALL, and I think that has shown to have great results. I don't think that we have the tools yet, at least for the younger patients in Ph negative. But I think that, yes, CAR T-cell I think is going to be part of that. So of course they get some chemo with their conditioning. But yeah, I think it's going to have to be a CAR T-cell based approach if we're going to be able to move it to the younger patients. Like, I know blina is a great therapy, but I don't think it's going to be enough to be curative for most younger patients, unless you give CAR T as part of that.
Mm-hmm. Yeah.
And Nicola, we have a question.
Yes.
I'm Chandra from Springfield, Massachusetts. With mini hyper-CVAD and venetoclax in elderly patients for Ph negative BALL, is it okay to move consolidation with blina, and if so, how many cycles instead of POMP? I have a patient who doesn't want to do POMP, and is it okay to substitute blinatumomab, and if so, how many cycles?
So just to clarify, mini CVD venetoclax for newly diagnosed?
Yeah.
Okay, so interesting, because we haven't done that. So just because, I mean, I think that there's been interest in venetoclax. We did the mini CVD venetoclax, and then also one with navitoclax for relapsed refractory disease, because these patients who have already had blina, we don't have other good options. I think for us, we just, because INO and blina are so well established as effective therapies in B-cell ALL, that would be our front line, so mini CVD with INO. But let's say if you have a patient that you've treated with mini CVD venetoclax, and who's older, I think that, and depends how old?
70s.
Yeah, so I will say for patients in their 70s, we've moved to the INO blina and no POMP even. So it's just like I know blina, and we're waiting for all the data, but just because we actually have seen patients, we think POMP is like not much, but we've seen our older patients on POMP have still infections and other things. So I would give that patient blinatumomab. I think that you could perhaps omit POMP in a patient who's over 70. But we don't have a lot of data for that, but that's what I would consider that. But I would definitely give them blinatumomab consolidation.
So how many, like 4 cycles? I've gotten to 4 and they refuse to do more than that.
Well, if they refuse, then what can you do? No, I think 4 is reasonable. I mean, if 4 is reasonable. One thing, I don't know if the patient will be willing. So one thing that we do as a maintenance, if we do the POMP blina maintenance, it's 3 months of POMP, 1 blina, 3 months of POMP, 1 blina. Sometimes patients just need a break, and so I tell the patient, okay, well, we're going to do the blina, but we're going to do it every 3 to 4 months, right? So at least they feel like they get a break, they get the PICC line out, so it's not the same as like this back-to-back blina. So I would like to do that for a patient like that, because you are kind of giving them, minimizing their therapy, so I would like to, extend maybe the blina, or consider some inotuzumab as well, perhaps, but yeah.
Okay, yeah. We could go on hours with such great colleagues here and with a great audience, but I think we come to the end now. And I thank you very much for joining us. Thank you, both of you, for the wonderful discussion. We have a great outlook for the future of ALL management. That's very important. We have new standard therapies, but we have additional new drugs which can further improve our strategies. So it will be an exciting future. Thank you very much.
Thank you.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board for Accreditation in Hematology. This activity is developed with our educational partner, the HealthTree Foundation for Acute Lymphoblastic Leukemia. This activity is supported by an independent educational grant from AstraZeneca. To access all materials for this activity, visit peerview.com/AEN860.